Good morning, everyone. Welcome to our community of practice for family doctors for COVID-19. As usual, we're delighted to welcome you. I'm Dr. Tara Kiran. I'm a family doctor working at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family Community Medicine at the University of Toronto. We're really pleased to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over right now to Dr. Liz Maga to provide a bit of an introduction.
Thanks so much. Yeah, so really great to be here. And this is the information about the session. The panelists will be introducing themselves in a moment. We're delighted to have Dr. Nisha Thampi and Dr. Jeff Kwong join us today. Next slide. I'm going to read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous peoples have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation.
So yeah, I always like to use this time to reflect on injustices past and present. And if you guys haven't had a chance to, I really recommend reading the most recent issue of The Local that's really focusing on Indigenous people. And I thought this article documenting the history of Indian hospitals and the segregation and discrimination and awful practices that occurred there was really eye-opening for me and a good reminder of how the injustices really permeated medicine as well as places like schools and other areas of society. Next slide. This is, of course, I think now 15 months into our sessions, and I wanted to just give a shout out to our planning committee and also let people know that all of our past sessions are available on our website. We're going to be referencing probably some of them today, and so please go on and take a look at them. And if you do watch them after the fact, you will get main pro credits for that as well. Next slide. So I'm delighted to welcome our panelists today, and I'm going to let them introduce themselves. Next slide. So Nisha, do you want to go first?
Sure. I'm Nisha Thampi. I'm a pediatric infectious disease physician and infection prevention and control medical director at CHIO in Ottawa.
Great. And I'm Jeff Kwong. I'm a family doctor at Toronto Western Family Health Team, as well as a senior scientist at ICES and also at Public Health Ontario. And these are my conflicts, some research funding and some honoraria from College of Family Physicians for doing these talks.
Next slide, and Liz.
Oh my goodness, Liz Maga, family doctor in Ottawa, and I'm the president of the Ontario College of Family Physicians, and I receive a stipend for that role.
And I'm Tara Kiran, and I've listed here a number of organizations that get salary support and grants from. The only for-profit one is Gilead Sciences for a study on hepatitis C. Next slide. So we're of course delighted to welcome all of you who've really contributed to developing this session today. You're from the GTA, but all across Ontario. Next slide. I know that many of you are seasoned attendees, but just a reminder, please put your questions in the Q&A. We will be prioritizing the ones that get the most thumbs up. So please read the questions and give a thumbs up to the ones that you like, rather than, and if there's one that's already there that someone else put, rather than typing your own, put a thumbs up to that. Please do also read the answered section because our panelists do a great job answering things through typing. I will be taking up the most popular ones in general live as well. If you have things that you want to share yourself, thoughts, resources, please do put them in the chat. It's always wonderful to hear from all of you so that we can learn and share together. Next slide. I did want to just mention that we are going to focus on some of these topics. Sorry, I think the title is wrong here, but these are the topics that we're going to focus on today, based on some of the the questions that you submitted. We're going to talk about mixing and matching. We're going to talk a lot about kids, the risk of myocarditis and what the latest evidence is. Jeff's going to give us the latest on the Delta variant. Liz is going to talk a little bit about the approach to office-based care now, and we'll touch on what to do around the fully vaccinated, because I know that was a question that many people asked. So next slide. I do want to start off just by acknowledging today, I think that many of us may be feeling quite frustrated, maybe a little bit dejected. I think many of us recently opened up our College of Family Physicians journal and felt the Canadian Family Physician Journal and felt maybe disheartened to read the editorial there that felt disrespectful, to be honest, at a time when we are all working so hard. And it was great to actually read so many thoughtful online comments from our colleagues, really challenging what was written in the editorial. If you haven't checked that out, please do check the online version out. I also did want to acknowledge the confusion that has resulted and frustration that's resulted from the NACI guidance statement that was issued yesterday. So I've displayed that statement here today, and that of course is the latest advice that NACI is providing on mixing and matching. So they reiterate that those who got a first dose of an mRNA should be offered the same mRNA for their second dose, but if the product isn't ready available, it's okay, it's interchangeable with another mRNA product. But then they do go on to say that an mRNA vaccine is now preferred as the second dose for individuals who received a first dose of the AstraZeneca vaccine. And they cite the fact that there is now emerging evidence related to immune response, and of course the safety concerns around VITT. At the same time, they say, rest assured, if you got AZ, you've got good protection against infection and excellent protection against severe disease and hospitalizations. And I think Jeff is going to go into some of that data around, what the evidence is around people with doubly vaccinated AZ, and the Delta variant later on. But I wanted to acknowledge that this was for many people a frustrating statement, and it, of course, partly frustrating because it's a pivot yet again, and many people are now having to reschedule doses or clinics that they have put into place. Prior to the COP today, I did reach out to Monica Pai, who was on a previous session. She's a hematologist who's really been at the forefront of VITT here in Ontario. And she assured us that she didn't think there was any new update on the risk of VITT with second dose. That risk is still estimated to be 1 in 600,000, or weirdly, it sounds like it may even be 0, but it's not really clear at this point. I think others, like infectious disease specialists like Alison McGeer, wonder if it might increase, but at this point, the risk is thought to be 1 in 600,000, and there's no change in that update. Next slide. People also asked, has there been any new evidence around mixing and matching and the effectiveness of mixing and matching AZ and then an mRNA? New evidence since the 2 weeks since we had our last session. And in general, I think the answer is no. At this time, all we have is immunogenicity data. We do not have effectiveness data directly for the AZ mRNA combination. And I thought this slide from Sabina Vora-Miller from Unambiguous Science did a great job in summarizing the 4 trials that did look at immunogenicity. Not all of them did a direct comparison of, AZ, Pfizer. So, you can take a look at these. We'll circulate the slides afterwards. I think the bottom line is there is some evidence of immune boosting effect if you have AZ, Pfizer compared to just AZ. However, I think the really important piece is that if you have AZ, as Jeff and others will share, there's really good evidence that it does protect you against serious infections and hospitalizations. Next slide. I also wanted to share this decision aid that we put together, our colleagues. So I think that right now, I apologize, I think I had put both links here, but we actually have both a 1-pager and a 6-pager, and I'll make sure that we have the 6-pager link in the chat for you. Both the 1 and the 6-pager are, I think, great resources still for patients. The 6-pager provides a lot of details around the evidence that can help people when they're making their decisions. So again, it's a difficult, I find personally the NACI statement's a bit difficult to interpret when they use the term preferred, but we certainly know many of our patients have opted to get AZ, and that still offers them a lot of protection, and the bottom line continues to be get 2 doses. Next slide. I also think it's important to acknowledge that partly, we are where we are because, you guys as family doctors have helped us to step up to get as many vaccines in arms as possible, and our patients have as well. And so that includes patients who've stepped up to get AZ early on. So now we're at the head of the pack when it comes to people who have had first doses. And Jeff's going to talk a little bit more later on about who's still remaining, who hasn't got their first dose yet, and what can we do about it. So with that, I'm just going to go to the next slide, and I'm going to turn it over with no further ado to Nisha, who's going to speak a little bit more about kids and the vaccines. Next slide.
Thanks, Tara. Just a little bit of level setting on what the situation is in Ontario. So we have at least, it's been shown for I'd say a year now that most kids will have asymptomatic infection or at least only one mild symptom. So the clinical course is very mild in general, with a much lower proportion of severe outcomes. So we can see with hospitalizations in under 18 versus adults, significantly lower ICU admissions as well, and then 1 death reported in Ontario compared to more than 7,000 among adults. Next slide, please. And this is, the concern around COVID has been not just really about the clinical course, but also about the sequelae. And one of them has been these post-COVID conditions, which is a grab bag term or an umbrella term for the wide range of physical and mental consequences that some patients will experience and that are present 4 or more weeks after the onset of SARS-CoV-2 infection. And this image to me was really helpful as a visual learner to highlight where the post-acute COVID-19 symptoms fit into the timeline after an individual is infected and becomes symptomatic or remains asymptomatic with SARS-CoV-2. I've put in a link to the CDC because just this week they put out interim guidance on post-COVID conditions, not necessarily, not restricted to kids. In fact, most of it was around adults. But it's to get a little more insight into the condition that typically involves fatigue, neuropsychiatric symptoms, and cough. And I'd say that those are the symptoms that we've seen in kids too, in Ottawa and in other centers, and typically persisting more than 3 weeks out from illness onset or a positive test. Next slide, please. The other consequence that we worry about following infection in kids is multi-system inflammatory syndrome in children. And this is a post-viral hyperinflammatory condition affecting multiple organ systems following SARS-CoV-2 infection. And it has a similar clinical presentation to Kawasaki disease. It generally occurs 2 to 6 weeks after exposure to SARS-CoV-2, and it's thought to be related to this enhanced immune response rather than an active viral replication and infection. And I put these symptoms there because one thing that we've noted in kids is the presence of acute GI symptoms. And so we've had a couple of situations where kids have come in with what looks and sounds like acute appendicitis, and their appendix actually looks fine when they end up going to the OR. But to think about one of the non-jokes that I make is most of ID is in the history, and it's about taking that history of an exposure or symptoms concerning foreign infection, which in this period of time is pretty exclusively SARS-CoV-2 that's circulating in our community and not other viruses. Different with MIS-C compared to acute COVID infection is that these kids have required admission and specifically ICU admission in 80% of cases. Their myocarditis has also been part of the clinical presentation in 40 to 60% of kids, and there's been reported higher risk groups among Black children aged 6 to 12 years old and from lower socioeconomic strata. And just to put a local context to it, at Sick Kids back in March, they reported 130 patients with MIS-C, but only 20% of these kids were white. So it just speaks to the demographic differences that we're seeing. Next slide. So when we cannot protect children from the vaccine because of eligibility concerns, we have more evidence that adult immunization can protect kids. And this is an image from a recent COVID science table brief on lessons learned from Israel's reopening. And you can see here that, in March 7th, when they reopened, the immunization among adults, meaning second dose, 40% of adults had received their second dose at this point, and it peaked at 60%, and we saw a nice indirect or population effect of vaccination among adults in the pediatric population, speaking to the value of immunizing adults to protect kids. Next slide. So the goal for vaccines in children is to control transmission and to prevent illness and severe complications. Our approach among adults has been to prevent morbidity and mortality and then to control spread. So it's a bit of a pivot. And there have been some vaccines. There has been a vaccine approved for youth under 18, and that's the Pfizer-BioNTech at the same dose and interval as in adults. And Moderna has submitted its application for approval for those 12 to 17-year-olds as well. There's a trial underway for the Pfizer vaccine in Europe and the US, and I've put the doses there for the different age groups. And the reason for these smaller dosing is because the younger you are, well, number one, kids are not little adults, and the younger you are, the more robust your immune response is and the more of a reaction you'll have. So essentially you can get by with less antigen, but the same immune response. So they have expected to put out their report the drug makers have said that we should expect a fall report on safety and the immune response. And in the US, looking to have it approved by the end of the year. Next slide, please. Okay, so what is the signal that we may be seeing after myocarditis? Well, it's been referred to as an adverse event of special interest. It was initially reported in Israel and the United States among adolescents or young adults, more frequently than older adults, male more frequently than female, after the second dose, more commonly than the first dose, and within the 4 days after immunization, although it's been reported out to 2 weeks. In Canada, we've had 35 reports up to June 4th, and in Ontario, 19 reports, of which 4 have been in individuals under 18 years and none hospitalized. Different from the US and Israel right now in Canada, we're not seeing higher rates reported among vaccine recipients of myocarditis than would be expected in the general population. But the number of second doses that we've administered in our younger ages is relatively small to date. Next slide. So this is a great reference from the Brighton collaboration for frontline physicians who may be assessing patients presenting with shortness of breath, chest pain, palpitations. Those are the most common symptoms that individuals with myocarditis have been presenting with. But we know that it can also include diaphoresis or sudden death. And these are symptoms to look for following immunization with an mRNA vaccine. And so in the Brighton collaboration has, I mean, it's a terrible slide to look at here, but I would encourage you to go to the source. And in the algorithm, there are levels of certainty in this algorithm according to clinical, biochemical, diagnostic imaging, and histological criteria, with level 1 and 2 reflecting definitive and probable cases of myocarditis. Next slide, please. So the current available data show that the clinical course of myocarditis and pericarditis after vaccination is generally self-resolving, and symptomatic relief can be achieved with NSAIDs. So when a patient, and I would just say, you know, when a patient presents with symptoms, what we've been sharing with our colleagues in pediatrics and in the hospital emergency department is to make sure that MIS-C has been ruled out, the multisystem inflammatory syndrome in children. Having said that, and that's only because we can see myocarditis, right, in 40 to 60% of kids with MIS-C, but all reported cases of myocarditis or pericarditis after vaccination in Ontario and other countries haven't shown any evidence of associated MIS-C. So it's more to rule out the diagnosis of MIS-C because that follows a different treatment pathway before being reassured if this is a mild presentation that this is an adverse event of special interest following immunization. I do anticipate further guidance coming about the need for a second dose among youth and the interval between the 2 doses in the context of full recovery of symptoms in the majority of patients in whom we have outcome data available. I would say that there is a special immunization clinic in different parts of Ontario that you can refer patients to if they've had an adverse event following the first dose to assist families with decisions around the second dose. And I anticipate this further guidance from the American equivalent of NACI, so the American, oh gosh, I'm sorry, I can't remember. It's the Immunization Committee, Committee of Immunization in the US, and NACI are having meetings next week around this information. Next slide. And I want to draw attention to this resource that's just, that's been posted in the last couple of weeks from the Children's COVID-19 Vaccine Advisory Table, of which I am a member. It's been a really excellent resource for parents, youth, and healthcare providers, as you can see on the top. And it includes information on the legal requirements for consent on for 12 to 17-year-olds, information about myocarditis, essentially links to other websites like the Public Health Agency of Canada, Public Health Ontario, and reminds us that kids are really keen on, many youth are keen on getting this vaccine, and how can we empower them with information to make an informed choice. Next slide.
So just wanted to share a few other resources, and thank you, Nisha, for that fantastic overview of COVID in kids and emerging evidence around myocarditis. So, you know, for people who are looking for more resources on vaccination in children and youth, I thought the CPS, the Canadian Pediatric Society statement was really helpful, and they seem to try and keep that up to date. Next slide. And also wanted to share this Healthy Debate article that I thought was helpful as well. And then finally, next slide, for those of you who may not have seen it, the Center for Effective Practices and our department have collaborated on a series of tools on virtual care and chronic condition management in virtual care. And actually our latest tool is on youth and young adult mood disorders. So of course, we've talked about COVID and the implications of COVID for youth and immunizations, but we also know that mood disorders have been really prevalent in this age group and are really hard to deal with. So I wanted to just provide a link to that resource and flag it for you if you haven't seen it already. So, without further ado, I'm just going to turn it to you, Nisha, with a couple of questions actually that have come up. I think one of them relates to ones that Jeff actually has given some answers to, but I think it would be great to get your take as well. So Alan Grill said, given the myocarditis signal in those receiving mRNA vaccines age 12 to 24, should we be delaying the second dose until more data comes in from the US? Is it possible kids, adolescents may only need one dose?
Yes and yes. Like, those are considerations that are actively being reviewed in the next week. So I'm definitely leaning in and looking for the outcomes of those conversations. We've been really fortunate to have almost real-time data available from the US, where they have done it in a 3-week interval, and we have never offered it as a 3-week interval, except for I think a small population of children who were at the highest risk of medical conditions early on in the vaccine rollout. So I think those are considerations that I think we may expect to see. It has to be balanced, I think, against the risk of being exposed to SARS-CoV-2, though, in terms of the dosing interval. Like, as we have differential strategies for hotspot communities or essential workers who may be who may be exposed to SARS-CoV-2 more frequently or intensely, there may be a consideration for healthy children who are not in hotspot communities, healthy children who are in hotspot communities, and immunocompromised children, or children who may go on to develop, who are at higher risk of developing complications from COVID infection, and what should be the dosing interval for them, and whether they even need a second dose. The other, sorry, I'll let you ask your question.
Well, just to follow up, I mean, I think Alan's trying to be really practical here, because he knows that there are many of our youth who are going to Toronto, and I've seen them actually at our hotspot clinics. They're, able to get a vaccine within 28 days of the first, or 21 days of the first, actually. Should we be telling those families to hold off and wait longer for their second dose? Like, what should our advice be to them?
Yeah, so because we haven't, I mean, our strategy for other populations has been 4 to 8 weeks, and we haven't seen the signal, that increase from the baseline that has been demonstrated in the US and Israel. It's hard for me to be straight and narrow, because I'm not sure how much of our data has been different from the US and Israeli experience, because we've had fewer kids getting their second doses versus giving those second doses at a later time, even in our higher risk populations. So right now, the guidance that came out yesterday from NACI was to follow the product monograph, but I know that today was actually supposed to be the discussion with ACIP, with an ACIP for next week. But I would say that if I were in your position, I think I would wait to next week to coming to that decision about whether we need to give that second dose at the 3-week mark versus at the 4-week mark, and again, balancing that with what's their likelihood of getting exposed to, say, the Delta variant, because specific to the Delta variant, we see increased protection conferred with the 2 doses, and whether that difference in getting the second dose can be delayed by a week versus wanting to start getting that added protection now, I think is a case-by-case conversation with families, and meeting them at their level of risk tolerance in the face of uncertainty. But I also, my last balancing point is that the vast majority of kids with myocarditis following immunization has been very mild. It's been very mild. So we're not, we may be not traumatized, but we may be more cautious because of our experiences with VIT and the messaging that we were giving before, that this is a much lower hazard for our community. But I recognize that these are children and young people who we're talking to, and there may be a high outrage associated with this relatively mild illness. So yeah, I don't envy the balancing conversations, but I think it's meeting families at their risk tolerance and at their and at their own risk of exposures.
Yeah, so I think some great points, and we're of course balancing a lot of uncertainty right now in a lot of areas. And so just on that point, I'm just going to ask Jeff if you could speak to a couple of questions you answered in the Q&A live. So one question I think that got a lot of thumbs up was from Brenda Lois, who said patients who had 2 AZ vaccines are asking if they can get an mRNA vaccine soon. So this goes to the idea of getting an mRNA booster if you had 2 AZ doses. Jeff, what's your thoughts on that?
Yeah, I mean, I think it's premature to offer a 3rd dose to anybody at this point. I mean, I think we need to, there's some people who don't have the 1st doses, and then there's lots of people who don't have their 2nd doses. I mean, I think 2 doses of AZ is perfectly fine, right? And so, you're going to have good protection. The question is, will you have like a lot better protection with a dose of mRNA on board? I mean, I think that, we don't, I think time will tell. And, maybe in like 6 months or whatever, if we need boosters, maybe, for those people to get an mRNA at that point would be very reasonable. I think, we do know that we have a huge supply of mRNA vaccines that Canada has purchased. So it's possible that they will be offered an mRNA vaccine. But I think for at least the next 2 months, I think it's probably premature. And I think they can rest assured that 2 doses of AZ will offer them good protection, even against the Delta variant. So.
Thank you. And so just on a similar point, so Michael Lepoy says, with this recent NACI recommendations, that the mRNA is preferred for those who got the 1st dose AZ, mRNA is preferred for 2nd dose. What should we advise those with a 2nd dose AZ appointment already booked? Should they rebook for an mRNA, or and how about those that already had their 2nd AZ dose? So I know you kind of answered a little bit of that, but I just think it would be helpful to hear it from you directly again. Yeah.
So I think what I said in my typed response, and I'll say again now, is that it's really a personal decision. I think it depends on each person's, risk tolerance or their risk of exposure. If they're like an essential worker who has to work outside the home, I think the prioritization would be to get that 2nd dose as soon as possible. And, even waiting 2 weeks or whatever to get an mRNA, it's not worth that additional risk, and they should just get the AZ now. But if they are able to stay at home and stay safe, and they don't mind waiting a few more weeks, then waiting for an mRNA is also a reasonable option as well. So
any evidence, Jeff or Nisha or others, what is the optimal interval for the 2nd dose mRNA after AZ? Is it 8 weeks, 10 weeks, 12 weeks? I think I can kind of hear Allison McGeer in my head here, but be interested in your thoughts too. And then I can project my inner Allison.
Yeah, I mean, what I can say, and I'll be talking a little bit about this, like the data show that, your 1st dose protection lasts a while. And this is stuff that I don't have any slides today, but this is data that we're like literally getting this week. 12 weeks is still got really good protection against severe outcomes after 1 dose. So, I mean, I think there's, I think the boost up from 1 dose to 2 doses is worthwhile. From the 70 something to 90 something is worthwhile. So you want to get that as soon as possible. But, speaking to the optimal interval, I think, all we've got are the immunogenicity studies. And we know that, the 12-week interval, you get more antibody response than the 4-week interval. And so whether it's like a linear sort of trend or, we don't really know. But I think, waiting 12 weeks is perfectly fine. Waiting longer might be fine too, might even be better. Who knows? We don't know.
Well, I guess I'd balance that with the flip side, Jeff, to what you first said, was that if you are in a Delta variant hotspot, getting that 2nd dose sooner is probably really important for you to protect yourself against the Delta variant. So, maybe you disagree there, but I think it seems to me that there's like a weighing of the benefits of the 2. So if you wait longer for your 2nd dose, even if it's AZ mRNA, you might get a bigger immune boost. But if you get the shorter interval, you'll be protected better sooner. And if you're at a high risk work environment or home environment, then that might be really important for you.
Yeah, absolutely. I mean, I think it's about short term, I think especially if you're in a hotspot or you're high risk because of your exposure, exposure like sort of risk, I would absolutely recommend getting a second dose ASAP, because the short-term benefit, I mean, we don't even know that the 12-week is necessarily better than the 4-week interval in the long run, right? We just know that they lead to more antibodies, but whether that translates to, a better effectiveness in terms of, outcomes, we don't know. And that's something that we're going to look at as well.
Thanks, Jeff. So another question that's been, asked, so Carol Silverstein says, how should we advise our seniors who are now double vaccinated and now want to go to grocery stores and patios, given the Delta variant and where we are now?
Yeah, I started typing a response to Carol's question and I didn't finish. I mean, once again, I think that's like a very personal decision. There's a lot of factors that need to be weighed in. I mean, I think overall, I'll say that, case counts are going down. Yeah, I know we have Delta around. I think I'm actually quite optimistic, and the data I'm going to show, will support why I'm optimistic, that I think we're not going to see a huge spike in Delta because of how many people have been vaccinated. And as long as we're doing safe activities, right? So like going to patios is probably safe, right? I mean, the worry that people have about opening up and all this sort of thing is it's not because of the patios per se, it's the kitchen staff, who that's where the risk of transmission is, right? The indoor staff who are supporting the patios, and so I guess we'll see. I mean, I think, I wouldn't say, let's go to all these indoor spaces without masks. I think we should keep the mask and all that stuff for, the foreseeable future, until we get like a meaningful proportion of the population with 2 doses. And so, I think it'll be, end of summer or late summer before we get to that point.
Thank you. So Eva Teitelbaum has asked a tricky question here. So can you advise patients about antibody testing? DynCare is offering antibody testing against the spike protein. The cost is $75. Is this test meaningful? Any takers on that question?
I don't know the answer to that. I mean, I just had a patient, I got the report yesterday saying that they went for antibody testing. And in that report, it explicitly says that, we cannot comment on, is this test meaningful against like vaccination, like protection through vaccination. So I'm not sure if if my patient had the DynCare test or not. And it said that they detected, all, forms of IgA, IgM, but I don't know the answer to this specific question.
Nisha or Liz, do you guys have any comments on that one?
My memory serves is that I don't think we thought that the DynCare test was able to detect, but we weren't sure about the Life Labs test, but I will be, I don't know
so
that
it sounds like something we're going to, so why don't we leave this one to something that we follow up with? So our team will follow up, we'll ask a couple of experts, and we'll get back to folks in our Q&A post session. So this is a really tricky one.
Allison should be able to answer this question.
Yeah.
So the only thing that I would add is that the challenge that I have with these antibody tests is that the absence of an antibody does not mean you don't have other forms of protection. So we can see, for example, like looking at other diseases that we know very well. For measles, you can be antibody negative after getting your 2 doses, but you still have evidence of cell-mediated immunity, which is not picked up in the antibody testing. So I think it really gets back to why they're doing the antibody testing, like what's the goal of it, and like the added value of it.
Thanks, Nisha. So I want to switch topics and switch gears a little bit to primary care and what we're doing in our clinics. And I'm going to turn it to you, Liz, for a couple of questions and then just to take us through sort of an update. So Catherine Kilpatrick asked here, please help with guidance for reopening our clinics and how to deal with staff who are afraid to or reluctant to provide care to non-vaccinated patients.
Yeah, so, I think we're all thinking about, reopening as vaccination increases in the population. And then all of us hopefully are have been booked or have already received our second dose, and our staff, our patient-facing staff have as well. So there aren't specific guidelines. I would say what we know has stayed the same at this point are the IPAC regulations, notwithstanding, the fact that prevalence is decreasing, and at the same time, we've got the variants and new information around the aerosol spread. So sort of two different push-pull on that side in terms of IPAC, but the Ontario guidance is the same. And obviously the size of our offices and our staffing and everything is the same. And those are really going to be important when we start to think about moving back towards what we had pre-pandemic. I think one big question will be, what's the right balance between virtual and in person? We saw the peak of the virtual, that's been coming down. If we look at what we're doing in our offices now, what is the right amount? I actually did a look through the jurisdictions across Canada. Does anyone have anything interesting? Manitoba is the only one who's actually put a number on the table about what's the right balance, which was curious to me that, they had gone that route. I don't know, there isn't good evidence yet to tell us what that is. They were suggesting, at this stage, if you're in what they called a red zone, you should be doing a third in person to 2/3 virtual. And if you were in an orange zone, so less prevalence, you could look at half. I don't think we have the evidence to really guide us. So in that context of lacking evidence, I would say most of us are I think, trying to look at what can we open up. I think shifting perhaps the way we're having those conversations with patients on the phone about, virtual first, which continues to be the ministry guidance, but maybe moving towards, the patient-centered approach of offering more in person. And I would really recommend, I went back and looked at the article that Kimberly Wintmute wrote in the CFP and about reopening 1 year ago when we were coming into the summer again. And I thought that was excellent in terms of guidance on being strategic about what you do to return us towards what things looked like pre-pandemic. So, let's start to prioritize. What are we doing really well virtually that we can continue? And probably that's a lot of the chronic disease care. Where could we look to really deal with the backlog? I think all of us are, considering that, probably vaccination, some of the preventative care that we, now have to do in person. So I think, as I say, there's uncertainty about the evidence about the right mix. There is no change right now in IPAC guidelines and on our, current office space, but I think I would encourage people to take a look at that article. The OCFP also put a great, with input from, others, including Tara, put together a good guide on in-person care and taking a look at that, and how do we start to move more in that direction. So those are a few thoughts that I have, and I think welcome people's comments in the chat about how you're having those conversations in your clinics and what's been shifting for you. I can absolutely, yeah. So I just was going to say specifically on the, sorry, the last thing I was just going to say is we had the conversation previously about, does the fact that we're double vaccinated or our patients are change what we're doing? And at this stage, no. It doesn't change how, may reduce our levels of concern for sure and make us feel, more comfort in what we're offering in person. And but it hasn't actually been reflected in a change in the IPAC guidelines that we're seeing from the ministry to this point.
And so what my understanding from you saying is that there isn't any clear projection around whether the phone visit codes will go away? Because that was another question somebody had.
Yeah, I think we have to direct those questions to the OMA. I know they're heavily involved in the, looking at, those codes and wanting to protect those codes. I think that's pretty critical for all of us because there is absolutely no question that, virtual care, including telephone, is here to stay. So, of course,
And Liz, did you have a short primary care update that you wanted to provide as well?
Yeah, I would be. And we had a couple of poll questions that we thought we might ask, but I'll just give a quick update because we met with the ministry yesterday. So first of all, to just, again, enormous kudos to all of you across the province in all of the work that you're doing on vaccination, the heavy lifting of counseling our patients, of helping them get appointments, and then those of you who are vaccinating. in your offices or outdoors as well. So we have about over 300,000 vaccines, over 350,000 vaccines given in primary care across the province. That was of midweek, and more than 500 sites offering vaccination. The Moderna continues to come to primary care. So there's another allotment of 60K that's coming this weekend, and we continue to advocate for more of that Moderna to come to us in primary care. We're hitting, when we're getting the Moderna, we're hitting our, using all those doses that we've been given, and in many cases exceeding that. We're seeing, really great work by primary care. And last thing I would say just around Pfizer, the messaging we got yesterday was, listen, if primary care is interested and willing to take Pfizer into their office, let your public health unit know. So, which, we've obviously all been, beating from the same drum on that, but that was an interesting message from them yesterday to specifically call that out. So I would encourage you, there are some public health units that are already giving Pfizer to primary care. And if that's not happening in your public health unit, to reach out to them. So we had a couple.
Do you want to launch the poll questions?
Yeah, we had a couple of polls. It'd be great. So the first one was just really to get a sense, to the point of that kind of moving back to, where are we now and where are we headed? Interested in understanding, what percentage of your patient visits right now are in person? So, maybe you're not doing any in-person visits at this time because of restrictions or your personal situation, and maybe you're doing more than 75%. So interested in knowing that, if people could vote.
So Olivia, I'll let you end the poll. I know that we're also a bit short on time, so I want to not take too long on this.
Yeah.
So if we've got a few responses, I think you can end the poll.
And I don't know if those
results
will come up.
Can you tell us what the answers are there? Perfect.
Yeah, so great range. So we're seeing vast majority open to some in person, and then moving towards, some practices up at 75%. So great. And the next question was, we're talking, we're certainly hearing talk of the closure of the mass vaccine clinics probably into the fall. That will happen. I don't know exactly what that's going to look like, if they're actually all going to close their doors, or they may stay open in a smaller way than what they are now. And yet there are many children, youth, families, and others who need to continue to be vaccinated. So we're interested to know maybe just launch the last of the three, the last of the three questions, Olivia, which is just, looking ahead. If you think about, would you be willing or able to vaccinate children, youth, and families, given that mass vaccine clinics look like they might close? This is a question we're being asked at the OCFP on behalf of our members, is to say, we know there's many who are doing this now. Are there others who might be able to do this? All right, so if people have voted, we can
while we do that, maybe Olivia, you can load up Jeff's slides, and we'll go to Jeff next.
Excellent.
And we see here that
amazing.
75%.
Thank you, everyone. Great. Okay, I'll hand back to Jeff.
Yeah. So Jeff, I apologize that we're giving you short shrift here. Actually, Olivia, maybe we'll just go through. We'll just skip over these and go just to Jeff's slides. All right, Jeff, over to you.
Yeah, no problem. I can go through this pretty quickly. So this is a technical briefing I'm going to talk about from the UK. They're coming out like weekly. This is number 15 from last week. This week's hasn't come out yet, as far as I've seen, as of yesterday. Can I have the next slide, please? So we can see that, these are like the cumulative cases after the 5th case identified. And you can see that all the other variants along the bottom there, and Delta stands out by itself. It's like it has grown quite quickly in the UK. Next slide, please. So we know that it is more transmissible, this Delta variant. It's about 60% more transmissible, and it also causes more severe illness. So about twice as likely to cause hospitalization than the Alpha variant. And so keep in mind that the Alpha variant was about 40% more transmissible than the original one that we were dealing with like last year. And so the Delta is even 60% more transmissible than the Alpha. Okay, next slide, please. And so in the UK, you can see that in these different settings, so schools, You can see this red is the Delta. It's grown quite a bit in recent weeks. And so, but you can see that, social care, I believe that's their nursing homes, it's very low. So I think this shows that the vaccines are working. They haven't been vaccinating school-age kids yet. They haven't, and so that's why I think that there's a lot of Delta going on in schools and workplaces. Okay, next slide, please. So these are a couple of studies showing a vaccine effectiveness against the Delta variant from the UK. Last week was the study that came out about symptomatic infection on the left. And on the right is this week's study that came out on hospitalization. So you can see summarized there vaccine effectiveness estimates for the Pfizer vaccine at the top, and then AstraZeneca at the bottom, 1 dose and 2 dose. So, it's gotten a lot of media attention that that 1 dose only provides 33% protection against the Delta, against symptomatic infection. But this week's study shows that it's got good level of protection against hospitalization with 1 dose. But keep in mind the relatively wide confidence intervals there. But with 2 doses, we are seeing 90-something% protection against for both of these vaccines. And so slightly lower VE against Delta compared to Alpha, at least against symptomatic infection, but it doesn't appear to be, it seems to be about similar for the severe outcomes. Next slide, please. So I'm just showing you this. This is some work that we've been doing in Ontario using data at ICS based on the lab testing data and the vaccination data that we have here. This is a preprint that we put out a few weeks ago. I'm just going to ask you to go to the next slide. So the data that were presented in that paper were data up till April 19th. And as of this week, we've updated up to May 30th. And so I'm going to talk a little bit about the latest stuff while I'm just presenting the slide, the figures from that preprint that was posted a few weeks ago. So this is looking at VE against symptomatic infection on the left-hand side and against severe outcomes, so that's hospitalization or death on the right-hand side. You can see that the VE estimates in the gray are for those who have only received 1 dose, and the black are those who have received 2 doses, and we've got the time since they received their dose. So you can see that VE starts at about 14 days and increases and sort of like peaks and plateaus at about 28 days and beyond. And so up in this figure, we've only got data up to 49 days and beyond. And now since then, we've got up to like 12 weeks. So 12 weeks is still about 70% VE. So it's, it's not like it drops off with this extended interval that we have in Canada. And again, severe outcomes, you can see that the VE gets to be really high, up to 90% by 35 days. And we're seeing that persisting up to, 7, 8, 9 weeks. So I think, actually, sorry, 9 weeks, yeah. So I think that's, really good news. And then, with the boost of the second dose, at least against symptomatic infection, you definitely see a boost. And then I guess a boost, against severe outcomes from like low 90s to high 90s with the second dose. Next slide, please. And then looking at it by age group, I think what's interesting here is that we see high VE in younger age groups, really early on. You can see here like up to 78% in the 16 to 39-year-olds by 14 to 20 days. Also 40 to 69 years, you can see that, by, the 21 days, you see, pretty good VE. Versus in the above 70 years, you can see it takes up to 28 days before they get into the 60% range. So I think we just need to be aware that older adults, it'll take them longer, but they do eventually get high VE. They just need longer to get there. Next slide. And then we've estimated VE against these different variants of concern. So this is back when they were still called by their numbers rather than the Greek alphabet names. And so this is alpha, and this is beta/gamma, and you can see that there's VE with 1 dose and with 2 doses against symptomatic infection and severe outcomes. And so now we've actually generated estimates against Delta that are about 60% against, so very similar to the Alpha actually here in Ontario, we're seeing, and different from the UK results, and then 90-something% with the second dose. And so good VE for both mRNA vaccines as well as AstraZeneca. That's not reflected in this slide. This slide is only the mRNA vaccines. At the time, we only had enough data to look at mRNA vaccines, but I'm hoping to get out these results next week or the week after to make them public, like at least posted as a preprint by then, showing good VE with 1 dose and 2 doses against the Delta variant for both AstraZeneca and the mRNA vaccines. Okay, next slide, please. So this is some work from the science table looking at kind of like the risk, and this is with a strategy that led to, that would recommended the hotspots. And so we know that, the areas of the province have had very high incidence of COVID, such as in Peel, in Northwest, and parts of Toronto and York region, versus other areas where there's been very low incidence of COVID. And so next slide, please. So what we've been reporting at ICS is, these risk deciles. So we've divided the Ontario population based on postal code into 10 deciles. So number 1 are the areas with the highest incidence of COVID infection over the course of the pandemic. Number 10 are the areas with the lowest incidence of COVID over the course of the pandemic. And you can look at coverage by the different age groups, and you can see that we've got really high coverage in the very oldest age groups, which is excellent, perhaps lower in the high risk deciles, decile number 1 compared to decile numbers, 8, 9, and 10. But in the younger age groups, we also got, pretty high coverage here in the sort of the middle age groups, the working age adults in the high risk areas, which is good. So this is what's the result of the hotspot strategy. And then the bottom here in the 12 to 15, lower, but they've only become eligible relatively recently. So overall, this is data that's as of Sunday, and is coming out on our dashboard later this morning. For about 71% of the eligible population have received at least 1 dose. Next slide. And then this is the change from the previous week. So from June 7th till June 13th, you can see that most of the increase has been among these young, 12 to 15, and then the 16 to 39, and then, smaller increases in the older age groups. This is for the, basically those who received the first dose. About a 3% increase overall in the province. Next slide. And you can see here, this is for those who are fully vaccinated. So those who have received 2 doses. And so you can see mostly it's, highest percentage in the older age groups, which is appropriate. And then also the hotspot strategy, again, we're seeing higher coverage in the high risk deciles 1, 2, and 3 compared to 8, 9, and 10. And it makes sense because, the people who got the first doses first are now getting their second doses first. And we're seeing, slightly overall better protection, like higher levels of coverage in those hotspots. Overall, 14% in the province. Next slide, and this is just showing the change. So we're increasing at a clip of 6% in 1 week for the second dose. So combined, basically, we did 3% of first doses, 6% of the population for second doses. So basically able to vaccinate like 9% of the eligible population each week now, which is more than like previously we're doing about 1% per day. Yeah, so you can see that most of it's happening in the older age groups right now. Okay, next slide. And just a quick slide, I know this is busy, but just looking at the colors, on the bottom right are long-term residents or Canadian-born individuals. On the upper left, we have refugees. Bottom left are recent immigrants, so people who may have immigrated after 2017. On the upper right, we have the other immigrant groups. So I think what I'm just trying to show here is that it's basically darkest green, in the bottom right compared to the upper left and and the lower left. So I think it's the newcomers and newcomer immigrants and refugees who I think are being left behind somewhat in our vaccine rollout. And I think those are the groups that we need to think of strategies to reach out to in the coming months. Next slide. I think there's only 2 more slides left. So what I did here was I picked out certain FSAs, and you can see that we've got the cases per 100. So you can see Jane and Finch has had 10% of the population test positive for COVID over the course of the pandemic. And it goes down to, Leaside at less than 2%. And so you can see the decile ranking there. It's not exactly the same because the decile ranking was done before the latest cases per 100. And you can see the first dose coverage for these areas. And this is for the overall population. So this includes those who are not eligible. So that's why these numbers are slightly lower. But you can see that, in Jane and Finch, it's only 54% of their population has received at least 1 dose versus 73% in Leaside and some of these other more affluent areas in Toronto at 74%. And then you can see the second dose. And I just ask you to go to the next slide, please, where I've just re-ranked them by the first dose. And you can see that, in general, like, Agincourt North, has lower second dose, compared to the Kingsway, but they have good, equivalent first dose. And so you can see basically the second dose, there have been some, uneven access issues, I guess. So some people have been able to get second doses more quickly, even though there has been, a hotspot strategy. There are areas, pockets of the province where, and scattered across the province where coverage is still low. And I think we need to be really careful. Places like Aylmer, Ontario, where, first dose and second dose coverage is very low. So I think we just need to be cognizant that, while we may think that, there's, high levels of coverage overall in the province, I think there are areas in the province where coverage is still low, and we need to be really careful. But in general, I am feeling very optimistic. I think if we can continue on our current trajectory for the next 2 months and get really as many people, both the first and second doses, as soon as possible, I think what we're seeing right now in Waterloo and Porcupine hopefully won't be replicated across the province. I mean, but hopefully, if there are cases, it doesn't lead to a lot of serious cases. I think the thing to keep in mind that is, even though there's with 2 doses, the protection of the vaccine effectiveness 90-something%, if we reopen too quickly and relax too many restrictions too quickly, there will be a lot of cases and we will see hospitalizations. So I think we just need to continue to be cautious, and that's why I think the province is doing the right thing in being cautious at the moment. So I think that's all I have to say for today.
Thanks so much, Jeff. I mean, I think your remarks really, first of all, illustrate the amount of work that you're doing on behalf of all of us. Olivia, maybe we'll just keep up the slides. We'll go to the second last slide because I know we're pretty much near the end here. But just wanted to thank you, Jeff, for that work that you're doing on behalf of all of us to really understand who's being left behind. I think some of the pieces that you've shown, I think, really highlight how we need to continue to prioritize certain hardest hit neighborhoods, including for second doses, and how we need a really focused, targeted strategy for first doses and second doses still in some neighborhoods, not necessarily in Toronto, but outside of Toronto as well. Really interesting to see Aylmer and Cornwall kind of light up there as low uptake of first doses, for example. But really also great to hear, that we're getting really good protection against the Delta variant with the 2-dose coverage that we're seeing here in Ontario, regardless of time span. And I found in particular, also that warning that with older people, it takes longer to build immunity. And so I think people are asking, what can older people do once they're doubly vaxxed? Please keep that slide from Jeff in mind as you're providing that advice. Next slide. So I just wanted to thank everyone who turned out today. As you know, we're going to have our recording up on our website. Usually that's up by Monday, sometimes by the end of day today. And we will also eventually post the slides there, as well as a curated question and answer document. And we'll continue to try and reach out to other experts to fill in some of the gaps for the Q&As that we weren't able to answer. I know there were 40 Q&As answered through typing by our panelists today, in addition to the ones that we took up live. So lots of great questions answered. We are looking forward to being back with you on July 9th. And then we'll have fewer sessions over the summer, but still continue to try and provide you with the needed updates that we know many of you have come to look forward to. So big thanks to Jeff and Nisha for joining us today, to my co-host Liz, to our back team, Olivia, who controlled the slides, our big OCFP and DFCM supporters, and all of you who continue to help us to make Canada, I think, one of the largest vaccinated, highest % vaccinated countries. So thanks to all of you for all the work you're doing. Take care.